Am I audible?
Yes, yes.
Yes.
Are you able to see the presentation?
Yes.
Yes. So let me first congratulate Dr. Vaishali and the team for organizing Synapse2023, a unique conference with a special focus on mind-body medicine, and it is for consecutive 4 years now. So I must congratulate to her. And in fact, this time she has given me the responsibility of an opening batsman. So I will try to make a good foundation for the to my best. I can lay a good foundation for this conference. So today's topic is on which I'm going to speak is the marker of allostasis and the overview. So let's first begin with a little bit theoretical concepts. All of you, right from the beginning in first year, you know the concept of homeostasis, which is a physiological response to a stimulus to maintain constant conditions in internal environment. And this internal environment actually is what is the natural design, all the physiological set points with which we are born. So body tries to maintain these internal conditions as far as possible to maintain homeostasis, and it's important for survival also. And what we actually try to maintain is all kind of physiological parameters like blood pressure, set points, pH, temperature, so on. And the allostasis is basically an adaptive physiological response to maintain homeostasis whenever body is exposed to stressful stimuli. So you can call the allostasis as an extension of homeostasis, where the stimuli is perceived as a stressful and then the body responds to that stimuli. And all of you know that no biological system is 100% efficient. So whenever we are exposed to any kind of stressful stimulus, the body responds to it. And when the stimulus is withdrawn, there is a natural homeostatic recovery that occurs. But as the biological system is not 100% effective or efficient, there is always an incomplete homeostatic recovery occurs, and therefore some amount of error always remains. So when we are repeatedly exposed to stressful stimuli, this amount of error, it builds up. So allostatic load is nothing but this built up error in the physiological system. So you can call it as an allostatic load as a multi-system physiological dysregulation, especially the regulation of PNIE, that is psycho, neuro, immune, endocrine axis. And that's this dysregulation sets in due to incomplete homeostatic recovery whenever we are exposed to repeated chronic stimulus that is perceived as a stress. What is the consequence of this? The consequence, you can see it in this slide. It is the gradual shift of physiological set point. So here you can see that whenever the stimuli is there, initially there is some allostatic response. When the stimuli is taken away, then you find there is a homeostatic recovery. When we repeatedly give us a stressful stimulus, you can see over here, the allostatic response goes on increasing and the homeostatic recovery is incomplete. And then you can see that the physiological set point with which we are born with, they already shift to a new set point level. So this gap or this difference between the set points with which we are born and the new level of set points which the chronic stress has, any chronic stimuli has shifted to, this is called as allostatic load. And this allostatic load puts actual natural load on this design. So we have to work now with this, all the organs we are born with to a higher set point levels, which is definitely a load to the body. So here now we can see that how this allostatic load, it is associated or related with the health non-communicable disease spectrum. Now here you can see that the allostatic load, it starts to build up even in the pre-disease condition. So it's not that only when we'll end up in disease or disease complication, the allostatic load is there on the body. Even in pre-disease states, the allostatic load starts building up. And all of you know that this non-communicable disease, it's a, you can say the one of the first killer of all kind of diseases. About 41 million people die each year, because of which constitute about 71% of deaths globally. And the cardiovascular diseases, out of this in all deaths, they account the most, and approximately 14 million people, they die because of CVDs. And the next to it is the diabetes complications, cancer, and so on. And the allostatic load is a major contributor for this global burden. Now, what actually causes or what actually leads to this buildup of allostatic load? So it is basically the disturbances in 4 pillars of health, which are also responsible for increasing the allostatic load. So if there is a disturbance in the sleep rhythm, GI rhythm, which includes hunger, satiety, energy and physical activity rhythms, and the psychological construct, comfort, meaningfulness, optimism, self-control. If there is any kind of disturbance in that, then it adds up in the already established allostatic load. And moreover, the disease process itself increases the allostatic load. And actually this sets up the vicious cycle of this allostatic load built up. So you can see over here in this previous slide that if we don't control the stage at the pre-disease or disease state, the allostatic load will go on increasing, and thereby the stages, you can see the non-communicable disease spectrum, it more shifts towards the complication. So it starts with pre-disease state, and over a period of time it shifts to disease complication. So now, how to address the issue of this allostatic load? What we should do about it? We know that there is allostatic load. How to go about it? So as it's for any medicine, it's a good assessment is a half management done. So if we know how to measure the allostatic load, we will know how to resolve this. So the quantification of the, so basically allostatic load measurement is based on the quantification of the representative markers from this psychoneuroimmune endocrine axis. So what are these markers? So there are 4 primary mediators which were originally studied whenever this concept of allostatic load has come in 70s. So initially the markers were all biochemical markers, and they represents the PNIE axis, and most important and most frequently studied is the cortisol. Then noradrenaline, adrenaline, and DHEA. After that, 2 newly added markers, which were newly included in the primary markers, primary marker category, are heart rate variability, which is, you can call it as a new vital, because it's a very, very important marker, which we will discuss over a period of time. And most importantly, out of this all markers which I have shown, heart rate variability is only the one which is a biophysical marker. Rest of them, they are the biochemical markers. So they represent body as biochemical structure, while HRV try to represent the whole body as a physical, biophysical, in a biophysical construct. So this is what is the basic difference, you can say. Then there are secondary markers which are there, and 6 secondary markers are there. They represent the structural remodeling of the receptor sites. So there are some cardiovascular markers like systolic blood pressure, diastolic blood pressure, heart rate, pulse pressure. So these are cardiovascular markers. Then there are metabolic markers like high density lipoproteins, cholesterols, West-to-hip ratio, glycated hemoglobin, BMI, etc. And then immune markers like C-reactive protein and interleukin-6 and fibrinogen. So You can see all the components representative from PNI axis. They are included in the allostatic load markers. So once you, what you have to do is that you have to measure these markers, and then the calculation of allostatic load index. That is done by standardized practices, and the most common method which is used to calculate allostatic load is to dichromatise the biomarker based on either the quartiles or based on the clinical cutoff. Like 0 code is given if the markers are in the normal range, and 1 means they are in a higher range than the accepted norms for that population. So we have to use the accepted norms for the our population in order to calculate the allostatic load index. And a high allostatic load means 3 or more biomarkers are in a high risk range. So this gives us the idea that how much is the allostatic load on the body. More the markers out of range, more is the allostatic load. Now coming to this heart rate variability, which is a marker for the allostatic load. It's as I have already mentioned that it's a new vital. It's a very, very important parameter. Why? Because first, it is non-invasive, easy to measure, and cost-effective marker of cardiac autonomic activity. So all these three qualities makes it to be more scalable marker. You can use it at a different population, in different population at over a wide range. Then a wide range application of this marker. It's used for diagnostic purpose, for screening, prognosis, and most important, now what we are seeing is that it's used in prediction, especially prediction of build-up of allostatic load. So this is a very good and most promising marker. Autonomic nervous system, and why this marker is important? Because it measures the cardiac autonomic activity. And all of you know that the autonomic nervous system, it's an important component of PNI. It regulates all internal organs and has a multi-system effect, including on HPA axis and immune system. So autonomic by its afferents and efferents has a direct effect on regulation of HPA axis as well as on the immune system. So you can call it as ANS as a candidate for a final common pathway for development of many diseases, mainly the NCDs. So that's why it is the HRV is the more robust and most important marker, because it is depicting the influence of ANS. Then autonomic dysregulation, especially progressive sympathetic overdrive, it is known to precede before the development of NCDs. So progressive sympathetic overload is considered to be an important in development of NCDs. Then autonomic dysfunction and reduced heart rate variability, both of them are shown to be associated with many NCDs, especially in metabolic syndrome spectrum, right from obesity to the complication of type 2 diabetes. And as I have said that HRV represent the biophysical construct, a different dimension to look towards body as against to the normal representation in biochemical format. So we must also have to look the body in a different perspective as a biophysical construct. So our experience with this HRV and allostatic load is that we have conducted many studies, right from predictions of diabetes complications to predictions of coronary artery. We have also used this as for prediction of preeclampsia and diagnosis of CAN in type 2 diabetes. And because of these studies which we have conducted, now we are able to give services to the patient for predictive, especially we are using it for test to refer the diabetic patients for the CAD referrals. Then for diagnosis of severity of CAN, that is cardiac autonomic neuropathy, isolated orthostatic hypotensions and POTS. So these are the services which over a period of time now we have started providing. The data speaks, because why I have shown this, that approximately 1,350 HRV card tests up till now we have done, and which included all diabetic patients, patients which are referred for coronary angiography, So we have included all these types of patient pre-eclampsia studies. We have conducted almost 113 samples. So like that, we have a lot of experience in conducting this kind of HRV card test. And these are our very, you can say, cardinal kind of papers which we have presented. ESD Berlin, where we have presented this heart rate variability indices in patients with micro and macrovascular complications of type 2 diabetes. It was initially was an observational study, but over a period of time, we have successfully converted this into the service. And where now we are even referring the patients who come to CART HRV test, the diabetic patients especially who show reduced HRV and without any clinical symptoms. And if we find that HRV is too low, then we definitely refer this patient for the angiography evaluation. So HRV in type 2, you can see over here that mean SDNN is a marker of HRV indices, and it's without complication, it is much more compared to the diabetes with complication. So if we get a patient without any kind of other screening test, and if we find that their heart rate variability is reduced, this is the right candidate to send for further evaluation of micro and macrovascular complications. So this paper we have presented at ESD Berlin. Then we have also seen the importance of this HRV as it captures the allostatic load, and which is better than the heart rate marker. So as you know, the cardiovascular marker is also heart rate. Allostatic marker is heart rate. So here we have observed that the HRV captures the load better. And you can see over here in this slide that the heart rate of all these patients is almost in the same physiological range. However, their variability is totally different. In the first left upper graph, it shows the variability in a normal person with a heart rate of 73, then a person with a diabetes with a heart rate of 80, then a diabetes progressive, uncontrolled diabetes, and then followed by diabetes with complications. In all these cases, you can see the variability is markedly reduced from normal distribution to the complication, and for the almost in the heart rate in the range of physiological range. So you can say that HRV actually captures the load better than the heart rate. Then we have also seen that HRV differentiate the extent of allostatic load with disease complications. Especially we have seen it in CAD, and that is coronary artery disease, and with heart failure, without heart failure. So here you can see that the variability is better with the patients who are actually referred for angiography, but they turned out to be CAD negative, and they were also not having a feature of heart failure. So their variability is much better compared to the patients who are having coronary artery disease as well as heart failure. So you can see there is a gradual progression of the HRV reduction from the non-complicated to complicated stages. Then we received different awards for these studies, like we have received the award at International Diabetes Summit in Pune in 2018. Then we have also presented the study with especially association of cardiac autonomic dysfunction with glycemic status and disease duration in patients with type 2 diabetes in RSSDI 2018. Then also published, also presented the study, association of prolonged QTC interval. Prolonged QTC is also a marker of autonomic dysfunction. So association of this prolonged QTC with cardiac autonomic dysfunction, again at RSSDI Ahmedabad. The salient finding of our study is that if there is a reduced HRV indices like SDNN, TP, LF, with the presence of CAN, which is assessed by a standard EVIX battery, and HbA1c greater than 7, duration of diabetes more than 5, and prolonged QTC, then these patients are at high risk for macro and microvascular complication. And even without any clinical symptoms suggestive of CAD, they are the patient we should refer for the angiography. Then we have also used artificial intelligence and machine learning for allostatic load quantification and prediction. We have presented this study at the International Conference for Machine Learning and Cybernetics in US. Then these are other publications related to the use of artificial intelligence. So technologically also we want to go ahead with this. Now the question comes, yes, we can measure the allostatic load. We know the markers. How to decrease the allostatic load? That's a very important question if we want to treat our patients. So the answer is the resilience building, that is to develop the counter mechanisms along with managing the disease so as to break this vicious cycle of allostatic load development. So along with disease management, if we start to build up some counter mechanism which can counter the allostatic load, so this will help to break this vicious cycle of disease and the allostatic load built up. Now, we have used this HRV even as a biomarker for resilience. So we have conducted a series of yogasana and HRV studies. So here we initially I would like to mention that what this resilience means. So really, resilience is the capacity and ability to recover from the difficulties or adapt quickly, or its toughness. So it's an opposite of allostatic load. Allostatic load tries to take you towards complication, while resilience tries to take you away from this complication towards healthy states. And improve HRV, it indicates better health and resilience. So HRV is a very good marker both to detect the allostatic load as well as to see whether, as it is a prognostic marker also, so we can use it to see that whether there is a improvement in resilience or improvement in health. So how, because there are a lot of studies which are already been done where it is shown that exercise improves HRV. So it's one of the original article meta-analysis randomized control trial, which has shown that exercise, all kind of exercises, they have used all kind of different types of aerobic exercises, and they have seen that over a period of time, HRV improves with exercise. There are a lot of other studies which have conducted, which have taken yoga as a measure. And this review article also demonstrated that this yoga improves HRV. So definitely these kind of techniques, they have a lot of impact on the resilience building, and they might be very, very helpful in our goal of patient treatment. So our own experience with this HRV resilience studies, we have conducted a lot of studies, especially the process studies where ANS modulation was observed or measured during the specific exercise or asana. We have also seen the effect of autonomic modulation in yoga naive individuals, in yoga trained individuals, how the autonomic nervous system, it modulates in these two different group of people. Then if you do the asana in a proper yogic way or in a exercise way, how the autonomic modulation differs. So you can see over here a lot of experiments that we have done, direct comparison of yoga with aerobic exercise. The same person is doing yoga as well as exercise, and then directly we have compared the autonomic modulation in these individuals. Then this, whether you are doing yoga in a proper relaxed way or in an exercise way, the HRV differs in these groups. So if we want to have some kind of yogic benefits, then we have to do the asana in a yogic way. Then modified asanas and aerobic exercise in yoga naive individuals, and we have compared their modulation with the experienced yoga practitioners. What we have observed, our important observations are that definitely yogasana have a training effect on autonomic modulation. Here you can see at baseline 6 months and after 1 year. So we have tracked down the individual up to 1.5 years, and then we have measured their responses during yogasana. And what we have observed, that mean RR, when we compared with resting and with Tadasana, the heart rate, the resting heart rate is less after 1 year of training. So definitely it marks that there is increase in vagal tone or parasympathetic modulation. Secondly, less increase in heart rate after 1 year of training indicates that circulatory demands are met at lower heart rates. So that is what is the marker of resilience, that you are able to do any activity, but the heart rate remains low. You don't require to pump the blood at very high speed. Even a little bit increase in heart rate and that will sufficient to meet the demand. So these activities are more relaxing in nature. It also indicates that you don't require much of energy. So they are quite relaxing asanas. Then here you can see the HF is a typical marker for vagal modulation. And what we see with the training is that less vagal withdrawal during Tadasana. So it's a very important observation. Why? And we are thinking that it's very useful for finding for the patients who are having orthostatic intolerance. So if we are able to train them for the Tadasana, the less vagal withdrawal I think is the first very good step for them not to land up in orthostatic intolerance. Then high vagal influence during Sarvangasana compared to resting. This graph you can see where compared to baseline, where when the person is doing Sarvangasana, the vagal withdrawal was much more, and after 1 year, instead of withdrawal, there is a augmentation in the vagal response modulation. So this is a quite interesting kind of finding, that after 1 year of training with this Sarvangasana, there is actually vagal augmentation during asana. So here it is possible that with few asanas, we are able to withdraw our vagus. With few asana, we can augment the vagus. With few asanas, we can we can little bit rise our sympathetic modulation. So by giving us different kind of postural possibilities, we are able to modulate our autonomic nervous system. But the most important thing to remember from this is that it takes at least 1 year for you to develop this kind of modulation. So yogasanas or any kind of this mind-body techniques, though it start working immediately, but the persistent effect or the actual learning effect you observe after at least 6 months of training. So you have to do yogasana for at least 6 months to train your autonomic nervous system. Then with this graph, you can see that we have, it's a cross-sectional study where we have compared the resting heart rate variability of trained yoga practitioner and with that of the patients with complication, without complication, yoga naive individual. So you can see that over in these groups, the HRV is actually reducing. The overall variability reduces. So it's the high variability is much higher in yoga practitioners compared to those who are having diabetes with complication. So this also indicates that if we are able to do such kind of practices, if we are able to give such kind of practices to our patient, then there is a possibility to counter this allostatic load which the disease itself is building. And the health pillars which are disturbed in patients, they are also contributing. So we have to look for all those mechanisms if we are able to improve the sleep, because sleep also has an effect on HRV. So if we are able to improve the sleep, if we are able to improve their digestive cycle, if we are able to improve energy cycles, and if we are able to modulate their autonomic nervous system in a different ways, so definitely there is a possibility to improve their HRV and resilience, which will be very useful to the patient. So on one side, there is a disease management, and on the other side, we are trying to improve the resilience of the patient by giving all these methodologies. And the most important, this is the effect that we have observed is few asanas, they actually cause sympathetic stimulation, and few asanas, there is a parasympathetic augmentation, like the asanas shown in green color. These are Sarvangasana and Shirshasana. So exactly opposite tilt of what normally we are in a standing position. So standing position are more like an exercise, while the inverted postures are more relaxing. This is what the study shows, which is under publication, which we have also presented at Indian Science Congress in 2015. So the salient finding of all these studies is what is I can see is the step towards evidence-based medicine for mind-body medicine. So based on these evidences, what people need, accordingly we can provide them these techniques. So if you want to improve their most of the time it is because of the sympathetic overdrive, which increases the overload, which actually is responsible for the allostatic load. So we have to give all those kind of techniques which either decreases the sympathetic drive or improves the vagal modulation or vagal drive. So any combination of these techniques can be used in order to reduce the allostatic load. And it requires time. It requires time to build resilience. It's a long duration activity, but it's definitely a helpful activity. So I thank all the audience and everyone for patiently listening, and I'm there to answer any queries or questions. Thank you very much. Thank you, Dr. Vaishali, for giving me this opportunity to talk on this much interested topic of allostatic load. Thank you.
Thank you, Dr. Leena, for dark load. What is it? How to identify simple methods like HRV and countering that allostatic load. How to build up resilience. Thank you so much.